Today we are honored to have a special speaker with us from Dartmouth College. Dr. Marsch is the director of the Center for Technology and Behavioral Health and one of the NIDA P30 Centers of Excellence, the director of the Northeast Node of the National Drug Abuse Clinical Trials Network, and the Andrew Wallace Professor in the Geisel School, hopefully I've said that right, of Medicine at Dartmouth College. Dr. Marsch's research focuses on the development, evaluation, and sustainable implementation of technology-based tools for behavior change, targeting a wide array of populations and health behaviors. And today she will talk to us about harnessing digital technologies and behavioral health, the state of the science. Please join me in a warm applause.
Well, thank you so much for that introduction, and also just for the invitation to be here. I really appreciate Maureen Walton and the Injury Center inviting me to come and present here today. I've had such a fun day just learning about the breadth and the rigor of the incredible work that many of you are doing, and I'm looking forward to learning more tomorrow. And this is actually my first time in Ann Arbor, so I'm just enjoying the beautiful campus and the beautiful weather. We had some snow flurries in Hanover, New Hampshire. So anyway, it's great to be here. I'm going to watch the clock here to make sure we have time for discussion at the end. But basically, I'm going to give you an overview of the state of the science of applying digital technologies to health and health behavior change. And I know many of you are doing some incredibly innovative work in this space, and that there's a strong portfolio here in this area. I'm going to tell you a little bit about the state of the science in the field broadly, and I'd like to tell you a little bit about our center, because I think there's a lot of points of potential interest and potential opportunities for collaboration with our group as well, and we also have a number of resources that may be of interest to you all. But I will surely protect time for discussion on the end. So first, I surely need to acknowledge support from the National Institute on Drug Abuse and other NIH institutes, and these are grants that support some of the data I'll be sharing with you today, including our center grant. And I'd also like to mention that in addition to my academic affiliation at Dartmouth College, I have an affiliation with two small businesses that are involved in deploying various technology-based therapeutic tools. And we can talk about this later, but our center is increasingly building out a number of different partnerships in academic industry partnerships and some academic industry governmental partnerships, with the mission of really sustainability of some of scaling up of the science and sustainability of resources that can have an impact at a population level. So today we're talking about the space of digital health and technology in this space. And when you think about digital technologies like web and mobile and cloud computing and data analytics, these are things that have pretty radically transformed our society. We do all kinds of things in new ways because of technology systems. So we do our finances online, we buy things online, people take classes online, we have social interactions online. And I am convinced from looking at the landscape of data from research in the health arena that we are similarly at a place where we're about to see a pretty transformative effect of technology in the health sector for increasing the quality and the reach and the cost effectiveness and opportunities for personalization of healthcare, both within as well as outside of healthcare systems. So the work that our center is engaged in is heavily with various clinical populations. Our center grant is from the National Institute on Drug Abuse, and so we have a critical mass of research in this space in the areas of addiction and mental health. But you see an explosion of interest in development of mobile health gadgets and apps and devices from the whole spectrum of preventative health and wellness to chronic disease management, for example. Some people call this the quantified self movement. You probably have heard this term, where there are new ways of data capture with mobile sensing, with remote data capture that can allow us to get new insights into health behavior and environment and context and opportunities for health behavior change. So we work in four sort of broad domains, although these are not distinct categories. They overlap quite a bit. But the data are increasingly showing that these types of technologies can have a big impact on how we understand and intervene in health behavior for lots of different populations. So first is the space of mobile technologies. And the idea here is that literally in your pocket, 24/7, anytime, anywhere, you can have access to an evidence-based, personalized tool, resource that can help people with achieving personal goals or helping them with health behavior management, chronic disease management, preventative health, etc. So I'll show you some statistics in a bit, but just underscoring the ubiquity of access to mobile devices and the growing prevalence worldwide and access to these tools and the opportunities to harness the prevalence of these tools for new ways of resource delivery. We also do a lot of work in the space of mobile and wearable sensing. So again, either your smartphones have extraordinary computational capacity and sensing capabilities and allow us to get all kinds of new insights into people's behavior, like looking at things like sociability or depression by measuring paralinguistic aspects of speech or activity levels or a wide array of things that you can look at with mobile sensing. And also we do a lot of work with wearable sensing as well. And again, these things overlap quite a bit, but smart watches, we have a project that NIDA's funded which is focused on detecting cocaine use just from a watch that measures intrabeat heart interval and distinguishes cocaine use from other types of stimulants. And again, this sort of sensing data can interface beautifully with intervention delivery. So again, these are not distinct categories, but sensing is very fascinating because it allows for this unobtrusive passive data collection and just a wealth of information about people's behavior, health, and environment that can be used for prompting intervention delivery in a personalized way. Social media, as we all know, are consumer-generated media that people produce in enormous quantities. So the market leader in this space still is Facebook. It's 1.7 billion active monthly users that are engaged in Facebook use, and there are many, many other types of social media that youth and adults engage in. And there are lots of interesting projects that are, I think the scope is expanding, that really allows us to get new insights, not only at an individual level, but even at market levels, looking at market trends at population levels in the health space by looking at social media in new ways, looking at analyzing the content and the sentiment and the topology of social networks and social media, and understanding sort of some of these relationships as they relate to risk behavior and opportunities for intervention delivery. So we can talk about that as well. And then finally, the space of data analytics. And again, this touches on all of the other three categories, the increasingly sophisticated types of tools that we can develop to glean these insights, to analyze these unprecedented sort of types of longitudinal data capture that we get. How do you, when you have a large amount of sensing data and data from people on mobile devices, how do you meaningfully make inferences about that and understand people's clinical trajectory and opportunities for sort of what are called just-in-time interventions in response to profiles of needs and preferences. And so this is another exciting area in this space that interfaces with intervention delivery. So why are we even looking at technology? These are some of the reasons that we got into this space. Probably the first projects in this space were in the late 90s or so. And one of the biggest potential benefits is the reach potential. This idea that you can push out widespread access to evidence-based resources. This widespread dissemination potential, and the idea that you can do so in a way that can ensure fidelity of intervention delivery. So you can develop systems that work in ways that can be wedded to the latest science and that can be flexibly changed to reflect changes in sort of the state of the science. And arguably, these types of methods of deploying interventions can offer really unprecedented levels of personalization. You can have different types of experiences based on different variables where it's really key to personalize. It might be on cultural considerations. It might be based on someone's level of cognitive functioning. So there's a real opportunity to have flexibly adaptive systems in that way. And many people talk about the opportunity for new levels of patient engagement with these tools, really sort of changing the traditional physician-patient dynamic and providing resources to people that can be complementary to that, but that can also allow people to play more of a leading role in their own healthcare management. Another potential benefit is this idea of on-demand access. So really, literally, anytime, anywhere, having access to something that may be useful to you. We do a lot of work, and I'll give you some examples with people trying to change problematic drug use. And it may be that you're feeling at risk of relapse at 2 o'clock in the morning on a Saturday night, and you may not have a clinician available to you at that time, but you may have something in your pocket, in your home environment, that can help you successfully navigate that. And there's a growing set of data that when mobile interventions are used in this way, sort of in this just-in-time way, that they can indeed help manage those conditions at that time and prevent escalation of the clinical problem and then costly escalation of healthcare utilization. So for one example of that is we do work with chronic pain patients who have what's called aberrant opioid taking behavior. And what we find is that when we give them a tool along with their sort of traditional model of pain specialty care, which is heavily opioid meds and injections and surgical procedures that a lot of these programs offer, if we give them a tool along with that they can access anytime, anywhere in the privacy of their own home, which is really focused on how do you keep chronic pain from ruining your life or your relationships? How do you pace your activities so you don't overdo it one day and then set yourself back so you can't achieve some goal, like maybe you want to watch your grandkids on Thursday? So if you give these resources to people to help them manage chronic pain, what we find is that we see that not only does it impact the aberrant opioid taking behavior and the pain interference behaviors, how much pain is impacting your life, but we see that it markedly reduces emergency department utilization for chronic pain visits. So the opportunities for not only addressing the clinical problem, but having cost implications for preventing costly healthcare utilization can be extraordinary. There are a lot of people working in this space of health disparities in digital health. And the idea being that even the most traditionally underserved and vulnerable populations are increasingly getting access to mobile devices worldwide. We're doing some projects in various countries in Latin America, for example, and some regions that we're working in may not even have landline infrastructure or clean water, but they have mobile devices. So it's just this opportunity to think about when we have healthcare disparities and access to resources, how again can we leverage the prevalence of these types of tools to address some of these disparities and offer care and resources in new ways. A number of the partners that we work with, such as healthcare organizations, are very interested in the role that digital technology can play in increasing service capacity. I'm going to show you some examples of some studies where we've seen this, but the idea is that by integrating technology-delivered resources as part of your service delivery model, that you can see more people, service more people, expand the scope of your offering with the same number of clinician resources. And that's really important in a lot of contexts where workforce isn't sufficient to meet need, like, for example, again, in addiction specialty programs that we work in a lot, the caseloads of clinicians can be extraordinarily high. Wait lists to get into these programs can be incredibly long. So if there are ways to embed technology as part of the way you offer care, then there are ways to think about expanding the scope of your service delivery. So I'm not trying to suggest that technology is the solution to all of our complex healthcare challenges, but the data are very compelling in this space that suggests that it can be a very important part of a multi-component solution that can have, if we really scale up the science in the way that can transform healthcare service delivery models, I think we are poised to have a pretty terrific public health impact. This is just one slide that underscores what I mentioned already, which is the growing access to technology tools worldwide. Most individuals around the world have access to a mobile phone service, and they're continuing to increase. Right now, it's about 7.5 billion mobile phone subscriptions worldwide. And many, not all of course, but many of these phones are smartphones. It's now more than half globally are, as of recent statistics, and those are also growing in access around the world, and they're projected to triple globally just to under 6 billion by 2019. So just briefly about our center before we get into the data. This is our center website for folks who may be interested in it, but the mission of our center is to use science to inform the development, and the systematic evaluation, as well as models of sustainable implementation of a wide array of technology-based therapeutic tools. We're heavily in the digital therapeutic space, but as I mentioned, involved in this whole sort of translational pipeline that includes basic science to intervention delivery. And we are housed at Dartmouth College, but I tell you this because our charge is really to be a national resource. And we have affiliates not only across all kinds of schools at Dartmouth, and the engineering school and computer science and medical school, the Dartmouth Institute for Healthcare Policy and Practice, and computer science, but also we have partners all around the country, and now a growing group of international partners in Latin America and in Europe that work together on the center. And it's really an interdisciplinary team. And as I know you all know from meetings today, this is so key to this kind of work, which is to not only have experts in behavioral health and sort of behavior change, but also people who specialize in ubiquitous computing and emerging technologies and data analytics in this space, and novel research designs for really understanding the impact that these types of tools can have. Health economics and implementation science and ethics. I think this is an issue we don't talk enough about in this space of big data and mobile health data is mobile health research ethics. I think this is a huge issue that should be part of every dialogue we have. So it's an interdisciplinary team, and we're involved in a lot of different projects across a lot of different populations, from substance use and mental health to chronic pain to medication adherence to a wide array of health behaviors to important behavioral dimensions of effective chronic disease management. So this work ranges from working with children and adolescents in prevention and intervention deliveries, all the way to aging populations and lots of other populations, and many of them are listed here: people with chronic drug use, mental illness, HIV, veterans, etc. And I mention this because what we find is that when we do this work on sort of different areas of health domains across different populations, across different contexts, and here's our contexts listed here, including primary care and specialty addiction and mental health programs, and hospitals and emergency rooms, criminal justice systems, schools, colleges, direct-to-consumer online. There's an immense sort of collective learning across this landscape of how you can think about the value of these types of tools for different end users in different contexts. And I'm going to talk a lot about that at the end, because it's really interesting to look at the shared learning across these different contexts and populations. So we structure our activities around this, what's called a stage model of intervention development. Many of you probably have seen that several NIH institutes have promoted this model. And it's really not intended to be a linear model, but a recursive model. So, but it starts, I don't know if you can see it very well in the back, but it starts at sort of stage 0 and sort of moves in a circular way. But stage 0 is really basic research in this space, which is really asking questions about if I'm developing some new sensor or some new prototype of a assessment tool or an intervention or some combination of that, looking at questions of feasibility and acceptability and comprehensibility, and really looking at the viability of that, and then moving into in an iterative way of developing and refining development of the intervention, testing at various stages, from efficacy trials to hybrid efficacy effectiveness trials to looking at effectiveness, cost effectiveness, and then to methods of implementation, which is really around, if you have an empirically supported innovation, how do you embed it in a system of care or some service delivery model that understands the impact to all the relevant stakeholders. So not just the patients or the consumers, but the clinicians, administrators, the payers, the regulatory structures that these systems exist within. And so there are research methods at all of these different levels of the stage model. And we find this framing it's really just a framework for the way we think about the scope of our activities, but it's incredibly helpful to think about this whole pipeline, even from the very beginning when you're developing a prototype of something, to think about the potential implementability of that tool down the track. So we are involved in these different stages. We infuse basic science questions in every initiative. Really, the goal is to create maximally potent and maximally implementable tools, really. That's the idea. And to really understand how this science can impact the way we deliver healthcare. So just briefly, we have 5 cores for folks who are interested. Again, I mention this because I know of the interest in this space and the great work here that intersects with some of the center's activities, and there are lots of pieces to what we're up to that may be of interest for some collaborative opportunities. We have an administrative core, sort of an infrastructure core, and then we have 4 main sort of science cores. One is on intervention, development, and evaluation. One is a pilot core where we can competitively in-house fund internal pilots. One is a core just on implementation science, as I mentioned, on really working with systems and stakeholders for understanding adoption. And then one is on emerging technologies and data analytics, which is really our sort of more basic science core, where we're really working with people specializing in ubiquitous computing and sensing technologies and wearables and things like that. We even have a project that we call Geek Chic, which is wearable jewelry, earrings, and all kinds of stuff. It's amazing what the sensors you can embed in these things. So the big picture of work in this field is reflected on this slide. So this is about maybe 15, 17 years of data. And the main finding in the literature is that if you develop these types of health behavior change tools, that's largely the space we work in, if you develop them well, and we could talk a lot about development, we spent a lot of the morning talking about development. Development's huge, and it hugely impacts engagement and outcomes. But if you have a process that's really reflective of an evolving state of the science in this, you generally see these patterns of results in the field, which is that you can get resources that are highly useful and acceptable to all kinds of different populations. You can see robust impacts on a lot of different areas of health behavior and health behavior change. There is a growing set of studies that shows that the outcomes you can get, the clinical outcomes you can get, are often as good as, sometimes better than what you get with clinician-delivered interventions. And some people really react to that and question, are you trying to replace clinicians with technology tools? And this is not the point of this line of research. I think what we know, and particularly people who work in the field of behavioral health, which is things like mental health and addiction, the workforce is so insufficient to address the need at scale, at a population level. And so there's a tremendous opportunity to think about these tools as sort of clinician extenders, a way to extend the reach and the impact of a clinician workforce. And it's important to know that they can have active ingredients that can be effective. There's also data to show that you can indeed increase the quality, reach, and personalization of care. We have health economists that we work with, mostly at Wharton School and UPenn, that have looked a lot at cost effectiveness in the space, and that there's a growing set of data showing in different contexts you can get resources that are cost effective. And I think what's most exciting is this idea of being able to develop tools that are adaptive, that can be flexibly responsive to people's changing needs and preferences over time. So they don't have to be static tools that always work the same way, but you can have resources that change based on people's health trajectories, and we can talk a bit about that toward the end. I want to just mention a few things about behavioral health, because this is something I know many of you are very familiar with, and this is very relevant to some of the data I'm going to be presenting. So we know that things like mental health and substance use disorders are pretty common. So about 1 in 4 to about 1 in 5 adults are diagnosable with one or more mental health problems. And about 1 in 10 are diagnosable with a substance use disorder. And we know that people who have these challenges are among the most frequent and costly utilizers of our healthcare system. These are just some estimates. Overall annual economic cost of mental health disorders is estimated at over $300 billion. The numbers have been increasing. And mental illness accounts for more disability in developed countries than many other groups of illnesses, including things like cancer and heart disease, which, if you don't know that field, is pretty striking to hear that statistic. So the point of this slide is that these are common and challenging disorders, but what's also important to understand is that these behavioral health challenges often also co-occur with and impact all kinds of areas of health and wellness, including chronic physical health disorders. So about 45% of Americans have one or more physical health, chronic health conditions. And what we know is, one example here is that folks with diabetes have roughly between 40 to 72% incidence are the estimates of co-occurring depression, and about 50% incidence of co-occurring anxiety. And when these things co-occur, the outcomes are worse and the cost of care is higher versus when the chronic physical health condition occurs in the absence of this behavioral health complexity. So you see all these kinds of things listed here: lower quality of life, poorer response to treatment, worse outcomes in terms of medical and psychiatric outcomes. So this example of depression and diabetes, when they co-occur, healthcare costs increase by about 50 to 75%. So behavioral health is important in its own regard. It's also important when you just think about any part of health that you care about. And we've had a changing healthcare landscape, as we know, in recent years, in marketplace and legislation that, among other things, has really promoted and created incentive systems to promote integrated care of behavioral health in primary care or other general medical settings, for example. And what we know is that there's just not a workforce to accommodate that. So if you think about screening for depression, addiction, and providing services for these things in the context of primary care, we don't have enough specialists in that context or enough systems to refer to that already are overburdened and have long wait lists. And so I mention this because this is one of the many sort of compelling areas where digital technologies could actually help facilitate integration, provide science-based resources in a way that can promote this integration and in a way that can do it without having to just focus entirely on workforce development, which we're never going to have enough workforce development to meet the need at scale. So, and this is also true for any sort of aspect of health behavior you think of. 40% of mortality and illness and suffering from chronic diseases is due to what we eat or whether or not we exercise or whether or not we smoke. And so the opportunities to provide personalized tools to people in new ways to help tackle these things and scale up the impact of what we do as a healthcare system, I think, are tremendous. So let's say that you are a healthcare system and you think, oh, this is really compelling, and I'd like to think about how do I offer digital technologies in my service delivery model? What's the best way to do this? Well, there are many, many ways you could think about this, and they vary a lot across context. But I'm going to talk about just some examples, and I'm going to show you data to correspond to each of these examples, so you can see when you integrate technology in different ways, what kinds of patterns of outcomes you can find. So one very sort of straightforward way you can think about this is just offering technology tools as a supplement to what you do already, as an adjunct to your existing model of care. And this, as I mentioned earlier, is often called this clinician extender model, right? It's just another tool in your toolbox, another resource you can make available to your clinicians, resources that are available to them in between contact with your healthcare system. An alternative approach is to have a partial replacement model where you actually partially replace some of a traditional clinician-patient interaction with a technology system. And you might wonder why you'd want to do that. But there are actually a lot of systems that have interest in this because, as I mentioned earlier, they can increase their service capacity. They can see more people with the same number of clinician resources. Or they could have more time freed up to deal with people who need more time and crises or have more intense medical needs. I'm going to show you some examples of this. And we also see models of standalone interventions, interventions that are direct to consumer. This might be particularly relevant in rural areas. It might be helpful in places where access to care is limited or people don't want to go to care. People in this country who have challenges of addiction or mental health very rarely go to our traditional models of care. 90% of people with these problems do not go to any system of care for these problems. We're touching 10% of people with these problems. I mean, this is an enormous opportunity to think about what are we doing and how can we think differently about engaging a larger percentage of these populations. So what I'd like to do is to show you some data that basically shows the types of outcomes you can get from these different models of implementation. And to do that, I'm going to use one tool that's sort of an exemplar of a tool. It happens to be a tool that we and others have had a chance to study for a long time. And I'm not going to talk a lot about the tool other than just say it's an interactive behavior therapy system that's self-directed and can be used in the context of a clinical service delivery model with people in other types of models of care. It's wedded to a very sort of state-of-the-science approach to behavior change for people with problematic drug use. But it's all delivered entirely using interactive technologies. It's a web-based system you can access on a mobile device or a desktop interface or a tablet. I'm not going to talk a lot about it, and I'd be happy to if people want to know more about it, but the point of using this tool is to show you when you use this tool in different models of service delivery, what kinds of outcomes can you get. Okay, so the first trial I'm going to tell you about was with opioid-dependent adults. And the design here is a 3-arm randomized controlled trial. Every single person that came into this study was opioid dependent, and everybody received a Suboxone medication, which I know many of you are aware of. It's a medication that's been shown to be very effective in stabilizing the brain neurochemistry of someone with opioid addiction. Everybody in the study got that. What varied here, what they were randomized on, was the type of treatment they got along with the medication. So they either went into an arm here, which reflected in the blue line here. They received this effective sort of state of the science behavioral treatment delivered by highly trained clinicians in one-on-one sessions 3 times a week. Lots of fidelity checks in place to make sure it was really reflecting the best practices of intervention delivery. Or they went into an arm here, which in that condition, the patients had a clinician, but they only saw them 1 out of every 6 sessions. And the rest of the time, 5 out of every 6 sessions, they actually went to, in this case, it was in a computer lab set up at the treatment site, where they one-on-one went through in a personalized interactive experience working with this technology tool. So they just checked in with a clinician every other week, 1 out of every 6 sessions. And then the group here in gray received what's considered standard addiction treatment in most of our addiction specialty programs around the country for treatment of opioid addiction, which is not reflective of this gold standard treatment model. So the point of this study is that when you offload, in this case, roughly 80% of your intervention delivery to the technology interactive platform, you can get outcomes that are as good as intervention delivered by highly trained clinicians delivering sort of the state of the science, both of which produced better outcomes than what we do typically in the US. And so we don't have enough clinicians delivering state of the science effective treatment in any way that's going to scale. And the whole country, as you are well aware, is engaged in a dialogue about our national opioid crisis. And so when you think about a scalable way to tackle that's effective, this could be one potential part of a solution. That's one design. Another design I'll just briefly mention to you was an effectiveness trial in outpatient addiction treatment in New York City. People coming in, it was a very simple 2-arm study. Went into either the treatment as usual model here, which is medication and clinician-delivered therapy, or they went into a model where their time with their clinician was cut in half, and the other half of the time was spent using this interactive technology platform. So what we saw is that when we reduced in half the patient-clinician contact time and now gave them the science-based interactive tool, we actually had significantly greater clinical outcomes, including, shown here, significantly greater abstinence from opioids. This was the problematic drug for this sample. Objectively measured, all of these are objectively measured with urine testing, relative to if this wasn't part of the model of care. So it's a way to infuse sort of science-based resources into a system that has variable quality in terms of the services that are offered. So that's another example in some contexts where this kind of a design may be helpful. There was a big clinical trials network study that basically showed the same thing, and I'm not going to talk about it because of time, but it was with a much broader group of polysubstance users. So the next study I'd like to mention highlights this example of what if you just offer this as a supplement to treatment? If you just say, okay, let's make this an adjunct to what we do. We don't touch our underlying service delivery model. So this was a small study. We have a big 3-arm study we're just finishing now to see if we can replicate these effects or what the outcomes are. But the point was when people came into outpatient addiction treatment, they either went into the standard model of care or they were given access to a mobile version of this interactive behavioral support system. And what we looked at was what happened during the first 12 weeks of their treatment episode. So this is a really critical time. Retention in drug abuse treatment is a very important predictor of longer term outcomes. It's a predictor of better success if you can retain people. So we looked at what happened during the first 12 weeks if you give people this simple tool versus you don't. And we saw, good feasibility and acceptability. People used it, and about 90% used the tool. From qualitative data, it seemed like people were using it at times that were clinically important to them. Like, this was another study we did in New York City. There was one example, a woman said that, every weekend she had to go to the Bronx, which was a historically high-risk environment for her. So every Thursday night before she went through this whole sort of what's called a self-management planning routine to really structure what she was going to do to be successful in the weekend and not relapsing when she was there, and reminding herself why she was in treatment. So it was really a planful kind of use of the tool. So the qualitative data were very interesting, and the quantitative data were very, very interesting. So this slide shows the percent of participants who were retained in the treatment program if they did versus did not have this app as part of the model. So if you have the app added to treatment, 84% of that sample stayed in the treatment program during this observation window of the first 3 months of treatment. And if they didn't have the app, we only kept 56% of them. So it just a simple app along with the care model, this is the kind of pattern that we saw. And the same pattern showed up when we looked at urine test results showing fewer, more abstinent, fewer positive urines for opioids when you have the app versus not. So the usage of this tool and the greater retention is paralleled with drug use data. So this is, again, an example of where, in a certain context, this type of a tool could add value and enhance the outcomes you see. And this, again, is just an exemplar of a literature that has shown this for lots of different populations. So I'm talking about drug use as an example here, but if you look across all kinds of different studies that have looked at all kinds of different populations, we reliably see a robust effect in many areas of behavioral health and health behavior change broadly, from interventions to, I mentioned the study for chronic pain patients, how it impacted their clinical outcomes and even their emergency department utilization. We see similar robust effects for smoking cessation and reducing impulsivity in kids and reducing HIV risk behavior and reducing clinical depression and targeting trauma and alcohol use and medical regimen adherence, for example. So there's this whole landscape that shows that you can get similar patterns of effects across a lot of different populations and a lot of different contexts. And what's really interesting is if you look at this literature and you see what really is driving change, the active ingredients of change, there's a lot of commonality in terms of the mechanisms of change. And I encourage you all to, for those who are in this space, to really systematically look at mechanisms of behavior change from how these tools work. And just as an aside, what's really interesting, we have one initiative in our center which is looking at mechanisms of health behavior change with digital therapeutics versus what we see with traditional sort of clinician-delivered interventions. And what we find is that the rate of change and the pattern of change seems to be different. When you think about it, this is sort of unprecedented to have anytime, anywhere access to resources versus seeing your therapist every other Thursday or twice a week or whatever the model is. So we're seeing in a growing number of studies earlier changes in these core mediators of change with technology interventions on several different studies. And some different, these don't work. They don't, sometimes we say, are you taking clinician-delivered therapy and delivering it on a technology platform? These are very different things. Clinicians can do things that technology systems can't do well. And technology can do things clinicians, can't do. So there's a real opportunity for these things to complement each other and this to be a new type of resource we offer. So this idea of mechanisms has been really important in understanding what's driving the effect. When we change drug use, when we change pain management, how are we doing it? What is actually the active ingredient of change? And this is really important for replicability. When it works versus doesn't work, why is that the case? I think what we're seeing is that it's so key to understand what's the main driver of change and targeting the intervention to those main drivers to get the replicable effects. So you know, as you look at this landscape of research, there's a lot of overlap in what drives change. What are the fundamental principles of the science of behavior change? And what we see is that a lot of the content and the core functionality of what drives change, really the principles of change, often are agnostic to population. Many of the core principles of the science of behavior change transcend population. And I think, you know, we're in a place now, and I'd love to hear your feedback on this, but we're in a place where we're developing a lot of siloed tools, right? You know, here's an app for depression, and here's an app for insomnia, and if you need an app to track your medication taking, use this other thing. And if you want to track your drinking or you have an app for smoking, that's a different thing. So there are all these sort of siloed apps popping up, but there's a tremendous opportunity to think about the state of the science of self-regulation and behavior change, and embracing some of the core principles of that and some of the core functionality that can apply to a lot of different end users, and then flexibly bring in population-specific resources as needed. So if someone comes in with depression and alcohol use, then you bring in resources for that. If you have problems with insomnia, hypertension, whatever, you bring in resources for that. But it can all happen in the context of an integrated mobile system. And it's not easy to do. We've been working on this for a long time. We're developing this system called Square 2, and the idea is to take, you know, 16, 17 years of research and put it into one platform that can flexibly adapt over time. But I'm excited about it because I think the idea is to really, is to have some more efficiency in the way we think about delivery of these things. So the core principles of this platform are cognitive behavioral therapy, which many of you work in this space, and there's a lot of evidence showing that this kind of approach can be helpful to a lot of different end users. Something called behavioral activation, which is this idea of how do you initiate and promote maintenance of health behavior change. Something called problem-solving therapy, which might sound very simple, but it's amazingly effective. Teaching people to understand how to recognize problems and brainstorm potential solutions and then trial these things to come up with solutions. I mean, this is one of the most effective treatments for depression, for example. The community reinforcement approach, which is really this idea of sort of lifestyle restructuring and sort of coming up with ways that your context and your social context can reinforce change. And then the field of behavioral economics, which is really around incentives around this, and how do you provide incentives to help with motivational change. And so the platform that we've been working on embraces these evidence-based approaches in the context of one platform that can be arguably, it's never going to be fully developed because it's an evolving system for arguably for any population over time. So the way it's structured, I'm going to just show you a couple screenshots, and then I want to make a few other points but save time for discussion. What we have found a lot when we look at engagement is that if the tools are developed to be responsive to what's important to you, you get a lot more engagement than if you say, you have disorder X, here's your intervention for disorder X. You have this problem, here's the therapeutic solution. What we find is that if we're really saying, you know, who's the person you want to be? What are your goals? What are your values? What's getting in the way of that? Maybe depression's getting in the way of that. Maybe alcohol use is getting in the way of that. Maybe something else is. Then if you have a tool that's really trying to help you tackle those things to help you achieve personal goals, that is a key part of engagement. We were talking a lot about adolescence this morning, and you know, kids don't want to constantly be told, you know, don't use drugs, let's track your drug use, but really what's important to them, right? And like, how do you provide resources to help them with that? And self-defeating patterns of drug use, you know, can get in the way of that. So this is all those principles I told you about, CBT and behavioral economics, but it doesn't use any of that jargon. It's really just about goals and values. And I don't think I'm going to go into it a lot because of time, and these slides are going to be available. But the whole process, just so you know, is structured to you can either have it's structured as ladders. I'll tell you just briefly. So you can have a whole list of ladders, and the idea of a ladder is, right, you start at a rung of a ladder and sort of you move up a ladder, almost like leveling up in a game as you sort of complete one. You can have ladders on different themes, like, substance use or panic attacks or whatever the issue is. Or you can create your own sort of ladder. You could use this tool, say you want to you want to run a marathon, or you want to climb a mountain. You can use the same tools for promoting that behavior and by sort of a process where you create your own sort of goal and use these resources and some of the core functionality to get there. So like with panic attacks, here are the rungs of the ladder, right? And the idea is that you move up the ladder as you complete one section, and as you're moving up the ladder, you're asked to start to apply some of what you're learning to what you do. So like, say you go to a therapist and they're helping you with panic attacks. They might ask you, between you now and your next session, I'd like you to try this, right? And some limited sort of gradual exposure, let's say. But the idea of this tool is that you literally can have it with you while you're doing these things. And so it's helping you almost like with the homework you get from a therapist, right? That you literally can have something with you that you can track your, all kinds of things. And I don't have time to tell you about it, but basically the idea is that it's a tool that can help you implement the skills and not just be educational content. So you sort of move up the rungs of the ladder, you're tracking all kinds of things. In this case, you can track, as you're learning things on your, throughout the rungs of the ladder, you can put this on a personal tracking grid, and you can track your historical grid over time. And I'll just tell you briefly what it is, but I don't have enough time to tell you. So let's say you're tracking, the frequency of panic attacks and sort of the how concerning it is to you on a scale of 0 to 100, or how often you're having automatic thoughts that can be problematic for panic attacks, or how often you're trying this skill of panic surfing in different situations or certain sensations you have. And you can plug this in literally, today, this is my data, and then my historical data, I can scroll down and see my history on all these different things, and it's a heat map kind of a grid, so you can see where you get into more problematic areas or not. And the idea here is that this is a visual interface to look at your different things you're tracking, in this case for panic attacks, but it could be for all kinds of different behavior change. So I'm going to just jump through this because of time. There's a social media component to this where you can share your trajectory and your successes and your challenges. You're chronicling your journey through using this, and you can share any rung that you want, any grid that you want from a rung with anyone that you want in an extended support network. So maybe it's your friend or your child or your significant other or your mom or your clinician, and you can share this, and there's not only a way that they can give this kind of feedback to you to support you or give you suggestions for how you can be more successful as you move in this path, but there's also a virtual prize cabinet. So the idea is, principles of it's called motivational incentives or contingency management, people call it. This idea of giving, it's really principles of behavioral economics, where you can pre-populate this cabinet with different incentives that your support network can also put in there. And maybe it's something personal, like they're going to make your favorite dinner, or something that, given whatever the relationship is, they can pre-populate that. And then as you move in a direction where you're achieving certain milestones, the system can deliver those incentives. So it's a way to help engage a social support network and some incentives to help you along sort of your personal path here. So I think there's a tremendous opportunity in this space to not only, there's all kinds of really important work, including work that many of you are doing and really trying to understand the value that these tools can have for lots of different end users, but I think there's also a lot of work that can happen on the translational end and really thinking about how do we take this science and create new models of service delivery and academic industry partnerships and trialing new digitally driven business models in this space and bringing in the right partners for that, not just the academic community, but bringing in all the stakeholders. There's a huge demand in the industry sector, in the governmental sector, and trying to figure out, how to sort of promote best practices in this space. So I think there's a tremendous opportunity for new partnerships and new levels of evaluation in evolving healthcare systems. And just because of time, I'm not going to talk about this a lot, but one thing I'll just mention is this concept of minimally disruptive healthcare. I don't know if any of you have heard about this one of our colleagues, Victor Montori, who's at Mayo Clinic, writes about this, and some of his colleagues. And the idea is that when you have multiple chronic physical health conditions, they're really burdensome, right? They're very burdensome. But the treatment for these things is incredibly burdensome. You have to go to this specialist for that. You have to take this medication and this medication. You have to go to a primary care doc. You have to coordinate all of this. It's a very complex system to navigate. So the idea is that minimally disruptive healthcare is to think about systems that reduce the burden of healthcare and the management of your healthcare. And I think there's a tremendous opportunity to think about how to use these types of tools and care coordination systems with technology platforms to help promote minimally disruptive healthcare. So I will shamelessly plug our book because we were really fortunate to have a wonderful group of, it's an edited volume, we have just amazing authors that have contributed to this, and it spans the whole landscape from development to all kinds of models of evaluation to implementation and sort of federal and regulatory space and future directions in the intersection of digital technology and behavioral health. And then I will stop there. This is my email address and also our center website. And I believe we do have a few minutes for questions. Thank you. Any questions or comments?
Just one quick question regarding the data you showed about the substance abuse patient population. Were they chronic pain patients?
Yeah, so the data that I showed you today, the graphs I showed you were not, it was not a population that had they could have had chronic pain. We didn't actively select people who had co-occurring chronic pain and addiction. These were people that were really involved in treatment for some kind of drug dependence. We have done work with the population you're talking about, the intersection of the two. Those weren't the graphs I showed you today. If you're interested in that, I can send you some papers on that.
So those studies were published as well?
Mm-hmm. Mm-hmm. Yeah. So if you want any papers on any of this, just send me an email. Okay.
I'd like to ask about the sustainability of these mobile interventions from the financial side, as well as the integration with the current health system side.
Yeah.
So, you have more and more of these plethora of these mobile health coming out.
Mm-hmm.
A lot of them, are, just like you said, are siloed. They can't be integrated in EHR. Okay, and maybe you can push for a treatment session and to get outcome results, but the data never gets back to whomever provider or the health system. So that really affects the sustainability of these endeavor. What do you think of that, and how would this be broken down to create a more, I guess, healthier environment for this type of mobile health?
Yeah, these are great questions. So let me start with the second piece. So I think that, as you're saying, there can be great value to the healthcare system if these data can be accessible and can help inform sort of what happens in that context. This is a very important area of research. I think sometimes people make the assumption that everything that you capture on a mobile device needs to go into the EHR. And what we find is that kind of mass sort of data sharing with the EHR, one, is often not welcome by the healthcare system, particularly physicians and clinicians, because it can often not be actionable data. It doesn't necessarily help them do their job better, and it may increase their liability. Right now, all of a sudden, I have all this other data I have to look at that patients are pushing to me, and I have more responsibility to look at that along with, my day job, right? So I think the value is in models where you can get data that can help the providers and the healthcare system better understand the needs and the clinical trajectory of the patients and help them do their job better. And so that matching, I think, is really, really important. Otherwise, it really kills the sustainability because clinicians, are not interested in that volume of data. But some of these tools are able to, the EHRs can pull selective data into it, but I think what we have found is that it's very important to create systems that can be flexibly deployed within and outside a healthcare system. So you can have back-end tracking and reporting to clinicians and EHRs of data, but also there's a lot of value in thinking about tools that don't always have to be wedded to healthcare systems. They can be accessible to the patient and can have a lot of value at an individual level as like a self-management tool. So I think there's two sort of big areas for when you think about health and healthcare. It doesn't have to always be access doesn't have to be wedded through, being prescribed or recommended by your provider, but there's a huge opportunity, as you're saying, to do that. And in terms of the business model, so, telehealth kinds of approaches where you have synchronous communication with clinician on a remote communication, that is reimbursed in many states. These types of tools are not reimbursed. There aren't codes like from CMS to activate to get reimbursement for this. That said, there's a lot of first movers in this space of adopting these, particularly in capitated payment models, because even though there's some investment in embedding this in what you offer, there's a lot of benefit in terms of the clinical outcomes and then the cost savings for you as a payer, let's say. So there are some payers, there are HMO systems that are embracing this as early adopters because there's a financial benefit, and it also often increases some of the clinical metrics in these systems. So, for a long time, there was an active dialogue where people were saying, oh, well, we need to get CMS to reimburse for these. I see that dialogue has shifted a bit. There's less focus on that, particularly with some of the incentive systems and payer models that have great value from adopting this. So, did I answer all the pieces of your question? Okay, thank you. That's a great question. We're over time. I'm happy to answer more questions, but I also want to respect people's time if you need to leave.
One last question. Do I see somewhere?
Yeah.
So a question about actually the backstage. How do you connect actually those data collected? Well, not necessarily back to the healthcare database, but there you have. How do you kind of suggest treatment, suggest interventions to individuals, or actually those kind of when to send a prompt, when to tell them to do something? That's kind of preset, or.
Are you saying when you send this to a healthcare system, or you're talking about the consumer, the end user?
Talking about how actually was Square 2, say, connected to a vast amount of data maybe you have already had.
Yeah.
And what's your experience in integrating the normal analytics with this platform?
Yeah. Well, that's a great question, and there's a lot still to be learned in this space, and I know that many folks here are doing some really great experimental designs to really understand some of these questions, and I love the work that the ISR group is doing here in this space of engagement with these tools. But I think that what we find is that there's some best practices for sort of intervention delivery for lots of different behaviors like smoking or changing alcohol use or whatever. And so the idea is to flexibly provide that based on what people identify as goals and values. There's a lot of interactive exercises that help identify that for the individual, and that can change over time. Also, as they track things, there's all kinds of troubleshooting sort of pieces that pop up based on that trajectory, and so you can't assume that you just sort of stick with a rigid model, because if it's not working, you need to have an adaptive system for that. And so the system's been developed to offer things in that way that can be flexibly changed over time, but also that they can prompt. People can help determine the frequency and timing of prompts, and then people can initiate contact at any time. If it's being used in combination with a clinical system, then you can have a clinician interface. Like, I didn't really show it to you, but this is like a heat map for clinicians. It's the same kind of grid structure. Let's say I have these patients, I'm tracking their PHQ scores, which is a measure of depression symptomatology, right? And I'm wanting to know, where people are with their depression scores. I can look for this person, today, and then historically where they were on their data, this person, et cetera. So you see the value of the number on the scale, from mild to severe depression. But the point is that it jumps out at you, like red is getting into the, range of somebody I need to pay attention to. So there are ways to think about flagging the clinicians with data sharing from the patient to the clinician in a way that this might be actionable data for at least those clinicians who want to see this kind of thing on a subset of patients, for example. But I think there's tremendous opportunity in research to best understand the value burden ratio. So how do you think about the best value and the best usage of these tools to the end user, the utility to the end user, but in a way that balances with burden? I mean, this is where passive sensing can add a lot of value. There's a lot still to be understood, I think, in how do you optimally pair passive sensing with EMA, sort of prompting people for queries and understanding models to integrate those two things to make them most efficient, to promote the best understanding of people's behavior and states of behavior, and to get the best engagement. Because people some of us were talking about this earlier, people are very intolerant of false positives. So like if the system says, oh, all your data suggests that you may be at risk of a psychotic episode or at risk of relapsing to drug use, and you know there's another very identifiable reason why your data might look that way, you're not going to tolerate those, sort of just-in-time interventions that don't match with your reality very long. You're going to toss the tool and not use it. So there's a lot that still needs to be, I think, evolved in the broad array of digital health tools and how they can integrate in ways to promote the best sort of understanding of people's behavior state, but also intervention delivery in response to that. And there's a lot of terrific work going on in this space, but there's still a lot to do. So thanks for the question.
So I think we'll have to wrap up there. We might be able to ask further questions down here individually after, and I just want to give a warm thank you, first of all, to our speaker, and then encourage you'll receive an email online as a survey, and if you can please go ahead and fill that out, the Injury Center would really appreciate that.
Thank you.
So thank you.
Yeah, thank you.